thank you guys for coming today. And part of the event today is to have one of these seminars. This one out of many series of seminars that we're going to be having within our association. And we're going to be talking in details today the need for everyone to be in attendance, because we've carefully selected some of the topics which we touch on wellness and our progress in this community. Essentially today, Dr. Okolo will be speaking on the effects and management of sickle cell anemia disease. Dr. Okolo is a GP at Southern Hospital. He's a consultant and expert, and our own. We're proud of him. So he's from Ebonyi State. So usually, sometimes we select our own people who will connect with us. Last week, Ebonyi Union had a seminar on diabetes, and they came with 4 consultants, and one of them a dietitian. So when they were breaking down the type of food we are going to eat, they actually demonstrated the quantity. They brought different types of food. So one of our members now said, if we are eating this quantity of food, that we're not going to survive in this country. Because we can't eat one slice of bread, one small pound of potato. So it is not our community. So that is why it's a very good feedback. It's funny, but it's a good feedback. We need to bring people that are from us, that understands us, that understands how we live, to actually explain things the way we understand. So that's how we are welcoming Dr. Okolo today. You can speak Igbo if you guys want to coachiate in Igbo.
Thank you for that beautiful introduction. When Joe was talking, he said I'm from Enugu State. I'm actually from Enugu State, but I have a very good, long history with Ebonyi State. I attended New Primary School one in Abakaliki. Yeah, Abakaliki, and then from there I went to Fresco. Abakaliki High School. Yeah, so before I left, I left Abakaliki, back to when my dad was transferred back to my hometown, my home local government. So yeah, so Abakaliki is a place that holds I hold dear to my heart. I live at I still remember the address of where we live, number 80 Video Street in Abakaliki town. Yeah, and I'm hoping that the next time I go to Nigeria, I have to go to Abakaliki. Because I have seen the transformation. I was talking to Joe the other day about the transformation Abakaliki has undergone, under this first governor. It's a very tremendous transformation. I'm not sure that if I get there now, I will be able to find my way. But I know where the general hospital was. I don't know if it's still there. I know where the prisons was. I don't know if it's still there. The police barracks and all those. I don't know if they're still there. So maybe those are the main. I attended the New Primary School 1 and 2 where I attended, and then Presco. I know Presco is no more. Presco is no more now, I think. Okay, they moved to somewhere else. Okay.
No more dust.
Anyway, yeah, exactly. No more dust. Yeah. So it's very good. And also, I was asking Joe the other day about Gilly Worm. Well, that used to be one of the main health issues in those days. I had a lot of my classmates, people that live in the suburbs. They would come to school and be picking out this worm from their body. So yeah, so I was happy when he told me that the story of Gilly Worm is almost non-existent. So which is very, very good. So today we are going to discuss this sickle cell disease. Just to give a little bit of historical context, the first known case of sickle cell disease was diagnosed in the year 1910 by a physician in Chicago. So after that, people started getting aware of it, and it became investigated, and then progress was made, and treatments were explored. Treatment options were explored, and so today we have a much better story than it was in 1910. So we're going to be following this outline. We're going to try and define it, and then discuss the epidemiology as well. Epidemiology is just talking about the worldwide distribution, where they are, in most cases are. And then we look at the structure and characteristics and chemical and physical properties of red blood cells. And then especially with special reference to the sickle cells that actually caused the problem, where the name came about. Then we look at the transmission, how it's transmitted from parents to offspring. Then we look at the types of sickle cells, the common types of sickle cells, and then how they present, the clinical symptoms and signs, and then management, and then mid-term conclusion. So I'm going to try as much as possible to use very simple languages that everybody will be able to understand and flow with. So talking about the epidemiology of sickle cell, by way of definition, it's a spectrum of inherited red blood cell disorders typified by the cell's appearance like a C-shaped palm tool called a sickle, thus affecting the cell's morphology, chemical reactions, and function within the blood vessel. Now, Abakaliki is known for rice cultivation. So I'm sure you know that there's this. I will show you the picture anyway. I will show a slide of the picture of what is called a sickle. I know it's very commonly used by people, the farmers that
palm.
Okay. We'll get to it. I'll show you the picture of what it looks like. So that's exactly what the red blood cell that causes this disease. That's what it looks like. Just like the shape of a sun, of a half moon. When you look at half moon, the way it appears. Yeah. So the highest incidence of this is okay. Sorry. Just to talk more about a little more about on the definition. So it's not just one disease. It's like a spectrum, like a group. Let me use that word. A group of diseases. Starts from one end and ends in the other end. From the least severe, if you want, to the most severe. So then talking about the incidence, it's highest. It's found more commonly among people, that is diagnosed more commonly among people from 6 months of age to 2 years. That's the common age group that diagnosis is made of, and then they are managed from there into adulthood. And one thing to note is that you can live. The fact that somebody has sickle cell doesn't mean that that person has been given a death sentence. You can still live a normal life and manage yourself if you adhere to the rules of the game. So once the diagnosis is made, and then it affects people of any race or ethnicity, though it seems to be more among people with low socioeconomic status. Now, I don't know how many of you, those that are married here, how many of you did their genotype, were asked to do their genotype before they got married? Because I know at a time it became very popular that the main aim of asking people to do that was actually because of this sickle cell, trying to break the transmission line of sickle cell. That's why a lot of churches and enlightened people came up with that idea at that time to insist. In fact, some churches will not wed you if you don't present those results, and it's all because of the effect of having someone that suffers from that disease in a family. It's not a very easy thing to deal with. Then it's regarded as the world's most common human genetic disease. So it's very, very common. Now, about 300,000 babies are born yearly with it, and with most of these cases occur in Nigeria, the Democratic Republic of Congo, and India. And out of this number that is born yearly, about 50 to 90% of them die by the age of 5. You know, so you can see that, I mean, it's a very big public health issue that we're dealing with. You know, so, and then in the US, it is more common in African Americans. It occurs in about 1 out of every 365 members of the African American community in the US. Unfortunately, I tried to see if I could get data on Nigeria from, you know, from their so-called center, Nigerian Center of Disease Control Institute. Unfortunately, I couldn't get anything, so that's why I have to you know, rely on the figures from other countries. Yeah. Now, and then in Canada, where we are, there are it's estimated that there are about 5,000 people living with sickle cell disease. And they have this Sickle Cell Association in Canada, you know, that has their offices somewhere in downtown Toronto. You know, so those ones, they're just a group of people, mostly people that have other relations, people that suffer from the, you know, from the disease, and people that have relations or friends that suffer from it, you know, just a kind of an advocacy body to keep putting pressure on the government to, you know, continue funding researches into finding better ways to control the disease and deal with it. So then the life expectancy of people with sickle cell, people that suffer from sickle cell, is generally reduced in comparison to the general population. You know, so a recent study estimated the life expectancy of adults with sickle cell disease to be 54 years, which is approximately 20 years shorter than that of normal adults without sickle cell disease. And I mean, it's not surprising, you know, it's not surprising because of the limitations. You know, the limitations the disease places on the people that suffer from it. So this is just a kind of a map to show you how the different parts of the world, you know, the distribution in the different parts of the world. You can see that those places that have the very dark red regions, you can see Nigeria is one of them. That's where you have the highest incidence of between 10,000 to 100,000 people, you know, within the population in the country. So that's to illustrate how widespread it is. And this is the shape of the instrument I was talking about, you know, the Sickle instrument. That's exactly what the cells look like. And we're going to see the cells now. Okay, so what we have there now is the shape of, you can see the normal red blood cells, okay? And the sickle cells, you can see them as, you know, as they're labeled. Now, the red blood cell is a very, very important cell. When you draw blood, blood is red in color, actually, because of the dominance of red blood cells and, you know, in the circulatory system. So, that's the color of this blood is color. So, the normal red blood cells are like donuts, okay? Donuts that without the opening in the middle. And that's exactly what the normal red blood cells look like. And the normal ones are, they are okay. You know, they have the normal quantity of hemoglobin, because red blood cells contain what we call hemoglobin. Okay? Now, the hemoglobins are the things that carry oxygen to the different organs in the body. So when you breathe the air into your lungs, you know, it diffuses into the red blood cells and then, you know, trapped by the hemoglobins and then carried around all over your body. You know, so the fact they are normal, you know, the fact that they're created normally, you know, the way they should be, so they don't have any issues. They move around, they change shape, according to the size of the blood vessels that they move through. So there's no issues with them. But the sickle cells have issues in the sense that they contain a lower number of quantity of hemoglobin than the red blood cells. So they're not able to carry as much oxygen as the red blood cells carry. And because of that, and some other chemical limitations they have in their chemical structure, they are not able to change their shape and form to be able to navigate the blood vessels when they're moving. So what happens is that they now tend to kind of come together, agglutinate and come together like gum together and form blood clots and get attached to the vessels. As you can see now, you see the normal blood vessel, and you see the normal red blood cell flowing in a normal capillary. The capillary is just a type of blood vessel. So then you see the sickle cells, you see how they are bunched up together. So it's this bunching up that brings about the problems they cause. Because when they bunch up, they stop further blood flow from the point where they bunched up. So let's say they bunch up in a blood vessel that's flowing to the heart, that supplies the heart. The heart muscles is blood. The heart muscles is blood. If they do that, then they cut off blood supply to the heart. That, in which case, that can result in a heart attack. It can result in a heart attack. If it happens in the lung, it can result in what they call pulmonary embolism. If it happens in the kidneys, it can lead to kidney failure. If it happens in the eyes, it can lead to loss of vision. So it affects almost, in fact, every organ in the body, the liver as well. And the spleen is an organ in the body that helps in the control of infection. When the body gets infected, most of the microorganisms that we come in contact with are destroyed in the spleen. So, but if these sickle cells disrupt the blood flow to the spleen and cause the spleen not to function well, then the tendency is that someone that gets infected, someone with sickle cell anemia, when the person gets infected, they are overwhelmed with the infection and they can die from there. A lot of times they die from sepsis, what we call sepsis, that's overwhelming infection. So that's that's to show you what happens in what the effect on blood vessels. Now, when you go to the hospital and a doctor recommends a blood film for you, like for people who come to the symptoms and signs, and then but when you look at a blood sample under the microscope, what we call a blood film, this is the picture you see. So you see there are red blood cells there are white cells, there are macrophages, there are all sorts of other components of blood, and then you see that there are the sickle cells, like these ones that have the same shape. So that's this is actually a film from somebody that has the disease. So as I tried to explain, I talked about this in a little bit. So the normal hemoglobin has 4 protein subunits. There's what we call 2 alpha subunits and 2 beta subunits. It's just names given to them because of their chemical composition and appearance. So the structural difference of sickle cells make them unable to behave normally, to do the normal things like carrying oxygen to the tissues and being able to change their shape and form to be able to flow well in blood vessels. And then the lower hemoglobin content in sickle cells results in low oxygen carrying ability, thereby starving vital organs such as the kidneys, eyes, brain, spleen, and spleen, leading to life-threatening consequences. The shorter lifespan creates undue demand on the production line in the bone marrow. Now, a normal red blood cell on the average, lives about 120 days, before they are destroyed naturally. So if your bone marrow produces red blood cell today, on the average, it can live for 4 months. That's 120 days. After which, the body, the spleen, especially, that's where the spleen and the liver, those are the 2 organs that are responsible for the breakdown and processing of old red blood cells. So, but because of somebody that has a lot of these sickle cells in their system, because they don't live as long as those the normal ones live, so it puts a lot of pressure on the bone marrow, to keep producing, even though they are not producing the right things, in the right quantity to keep somebody alive. So, yeah, so it puts a lot of pressure. So you see that sometimes those people, somebody can come. We'll talk about it when we come to the signs and symptoms. But one of the typical presentations is bone pain. Yeah. So that's where the thing comes from, overactivity in the marrows. Now, talking about the transmission from parents to offsprings. Okay. So there's the gene that codes for red blood cells. In every human being, there's what we call AA. Like when they ask you to go and do your genotype here, you have AA, you have AS. A is the normal red blood cells. Then S represents the sickle cells. And there are also other types of hemoglobins, like there's the C hemoglobin, there's what they call beta thalassemia. There are all sorts of them. I mean, even in animals have different hemoglobins from human beings, some animals anyway. So, but the one of interest here in humans is the A and the S and C, and then the beta. Those are the commonest ones. So, when you have a situation here, you have a father here and a mother here. So the R here represents the normal A. That's what we will call A component of hemoglobin, and the small r represents S. So these 2 people now, they are called carriers because they have half of it. They have the normal. The gene that codes for normal cells and the genes that code for abnormal cells. Okay, so if these 2 people now get married, okay, and have 4 children, the chances are that one of them, I hope you don't get confused by these lines that are drawn here, but the end result is that one of them will be unaffected. One of them will be RR, because one of them will get 1 R from the father and get another R from the mom. That's normal, the gene that codes for the normal hemoglobin. So that one is perfectly fine, no issues. Then you have here the second child here that will get the small R from the dad and the normal R from the mom. So that one is a carrier as well. Okay? Then you have the same situation applies here. This one gets normal R from the father and the abnormal one from the mom. And then this one ends up getting the abnormal genes from both of them. Okay? So this one obviously will come out as SS. If you do the genotype, it will be HBSSS. This one will be HBAS, this one will be HBAS, and this one will be HBAA. Okay? So that's how it works. That's why when I was asking you people about, those that did their genotype before they got married, yeah, if you have a man with AS and a woman with AS, the advice most of the time is usually for them to try not to marry. Not that for some people they could get married and have all their children normal. They could have all their children, AA, they could have all of them AS, and they could also have all of them SS. Okay? This is just a probability, of what in statistics, what the outcome is likely to be. That's what this. It doesn't mean that everybody will end up, will end up like this. So, but if you find out that if this person has the two normal, like AA, and then marries AS, that's okay. The worst case scenario, the worst thing that can happen to any of their kids is to be AS. None of them will end up being SS. Okay? So I hope I'm making sense.
Yes.
Okay.
Question.
Okay.
What couldn't it be easy for you to use instead of make things easier?
Okay, to use AS and this. Okay. Yeah. That was a mistake. I pulled this one from a data bank, so that's why it's like this. Yeah, but I should have used the AA, to make it. Yeah, but just understand it now that this represents AA, this represents AS, this represents AS, and this represents SS. Okay. So then. Talking about the common types of sickle cell disease. As I said before, sickle cell disease is a spectrum, under which you now have the different subtypes. So the type of sickle cell disease a person has will influence the symptoms they experience. The genes a person inherits determine the type of sickle cell disease they develop, just like I tried to explain in the diagram where we came out from. So the three commonest types are the HBSS, so that one is where the child inherits the two SS genes from both parents, and that is the one that is usually very, very troublesome. That is the one that from very early after birth, the person starts coming down with symptoms and signs of the disease, as we'll see later. Then the next one is SC, HBSC. This is a mild, very mild form of sickle cell disease. Now, for these people that have this, they are relatively okay with almost everything, except when they subject themselves to some very, very challenging situations. Like if they go on high altitudes where there's low oxygen in the air, that's where they can start having issues from there. Or they do very strenuous exercises, or they engage in some very risky behaviors. Even smoking can trigger off crisis in those people. But ordinarily, they are okay. They lead a normal life. Then the other subtype, the beta thalassemia, as I said, it's another variant of the disease, which is not very common. I mean, the people with that live very okay life, normal life, like every other person. And under that category, we also have two divisions, the beta O and beta A. So just for you don't need to bother about those ones. Now, we are now going to presentation. The clinical signs and symptoms. Now, signs are defined in the medical world. Signs are what a doctor sees when he comes to the office and you are examined. Okay, the things that we see are regarded as signs. Then the symptoms are the things that you complain about. Maybe you come and say, "Oh, I'm feeling very tired. I'm having pains, and my joints are swollen and things like that." Those are signs. So, say factors that can lead to the disease manifesting. And the manifestation of the disease is described as crisis. Okay, so include infections. Low oxygen tension from strenuous exercise and going to high altitude areas. Cold weather, even cold weather can trigger it. Dehydration, maybe these days is very, very hot. If you stay in the sun for a very long time and you don't rehydrate yourself, it can also trigger the attacks of sickle cell. And pregnancy can also trigger it in women. Alcohol consumption, physical and physiological stress, and medical conditions such as diabetes as well can trigger them. And then so most of the time people have fever. And as I tried to explain when I talked about the spleen and the effect when it's damaged, when it's not able to do its normal functions, that can result in fever and different ranges of temperature, usually high. In some people, they have a painful swelling of hands and feet, what we call dactylitis, and some people, their eyes are persistently yellow, what we call jaundice, and so for some people, when they pee, they pee, their pee is red, like a Coca-Cola color, or bloody. In extreme situations, it can actually be bloody. And then some people manifest with extreme tiredness. Some people have their problems with their breathing. Some people have persistent headaches, and in men, they can come down with painful erections and then poor vision, as I mentioned before. So these are just a few of the symptoms and the signs that people can come down with. Then coming to the management. So coming to the management, it's worth mentioning here that in a lot of places actually, I don't know about Nigeria really, but I know that over here, when a child is born, they screen. It's a normal thing they do before the child is released home. They have to screen them for sickle cell, for sickle cell disease, especially people from African Americans, because as I mentioned, in the intro, this sickle cell tends to be more common in people of low socioeconomic status, and I mean, low socioeconomic status comes with its different issues, financial issues, lack of education, lack of awareness, early marriages and things like that. People are forced into early marriages and things like that. And even in Canada here, I tried to see if the 5,000 people they estimated that live with this disease in Canada, if they are found among these native Indians, because that was my suspicion, but I searched for it, I couldn't see anything, but I have a very strong suspicion that it will be very, very high. The incidence will be very, very high in that population, because of the way they live their life, So, screening tests are done in babies, and if the person is okay, then nothing is done. And the type of test is used is what they call hemoglobin electrophoresis. Now, having made the diagnosis, which depends mainly on the presentation, what somebody comes with. But for the most part, because people are diagnosed early, and once they know, when they come to the hospital, they will even be the one to tell you that I have this. They will tell you that I have this, so that and that will now help you to now start knowing what further questions to ask, and what management modality to follow. So, but after diagnosis is made, for some people, if it's predominantly pain that the person has, you can use painkillers, in treating the person. You can also use blood transfusion. You can also use rehydration with IV fluids for people that are dehydrated, and their symptoms are arising from extreme dehydration. And then use of antibiotics where infections are found to be a component of the crisis. And then lifestyle management strategies such as frequent hand washing, drinking water as necessary, and avoiding high altitude and strenuous exercises are also adopted in managing the condition. And then there are researches going on, trying to find cure to it. Right now, there's no cure to it. You just manage it. But there are research is going on stem cell transplant, where they are trying to see if they can actually infuse cells from embryos and into people's bone marrow that can take over, be massively producing the bone marrow to kind of crowd out the abnormal cells and need to kill them. Those ones are still undergoing research, and so that's where we are now. And then talking about myths, misconceptions, and conclusion. A lot of you must have heard about this urban jetting back home. When people are born and all of a sudden, within a few years, especially in their infancy, and all of a sudden the person dies, and they attribute it to urban jetting. Someone actually did a study then in Nigeria and found out that most of those people were sicklers. Actually, yeah, they were sicklers. So, but because of lack of awareness on the part of the parents and the community generally, they are labeled as something else, and stigmatized and dealt with as people that are not worth living. And so it's one of the things that we try to fight these days with information and creating awareness. And then there's the issue of victim blaming and shaming, on victims, and which shouldn't be, but because of the society that we live in. In fact, there's this other thing they do in Igbo land. I don't know if they see the Osu caste system. Osu comes from different stories, and people that have this in their lineage, that die and all those that have issues. Some of them are labeled as Osu, and outcasts. If you want to get married, they will tell you, don't go near this person at all. So it befalls on us to educate and share information with our kith and kin to prevent having children with full-blown anemia, and for those affected to be encouraged to seek proper medical attention. If any of your relations is going to get married, you take your time, make it a point of duty to ask that question. Do you know your genotype? And if the person says no, then advise the person to go and get it done. And then also to get whoever the intending partner, to get their genotype done, to avoid all these issues. Now, so there's in recognition of the importance of this in the whole world. On June 19th, it's designated as Sickle Cell Day all over the world. So that day there's going to be seminars and awareness campaigns in different places, different organizations, just to sensitize people on the existence of this disease and how to try and avoid the continued propagation of it. So I think that brings us to the end of the presentation, and I want to say thank you and encourage you to keep up with getting yourself educated with some of these things. You never know who it will be beneficial to. Yeah. So if there are any questions, we can deal with that. Yeah.
Not really a question, but a comment.
Okay.
Just when you were talking about the researches that are going on with stem cell, at the moment, there is the bone marrow transplant. And the bone marrow transplant for the match has to be from within the family.
The family, yes.
Yeah,
yes.
cannot be outside. Siblings, it was the sibling.
Yeah.
At Toronto Sea Kids,
Okay.
they've done quite a few.
Okay.
Yeah. So and they are also using so that's good news. And there's the gene therapy.
Gene therapy, yeah.
There are so many.
There are so many researches going on in different areas, yeah.
So I think the problem we have in our community is that people feel stigmatized still. So that even when your child has it, you don't want to open up, you don't want to tell it when you're in the hospital, somebody asks you and you don't. Oh yeah, we just went for a routine thing. I think it's about time we have to understand. It's not really, it's not about you, right? I know you did mention it is commonly in people with low socioeconomic, but this is a hereditary disease. It really has nothing to do. The management might be affected by the economic factor.
Yeah.
But generally, it comes from, you know, the blood transmission.
No, definitely. Yeah. And I mentioned it.
So what I'm saying is that that's part of the stigma. Like I really don't know. So, but it's just, especially when you're living here, people have cancer. Even in our community, when somebody has cancer, no, you don't talk about it. Everything is stigmatized, and then you close up, and you don't get to have people get you network to where you can get help. So I think the whole point of this is awareness, knowing that this is just a disease like any disease. And here, management, like you said, you go for proper treatment, and you never know where you can get the help if you don't go to it. Right? So, thank you.
Thank you for your comment. That's what I mean.
So it's still about 300,000 people in Africa.
No. Every year, every year, all over the world. Yeah. Yeah, it's a huge number, but it's predominantly more in Nigeria.
Ghana. Yeah.
So these Obanje people are not Africans.
No.
Why did you talk?
The Obanjes are normal human beings. I mean, they are human beings like me and you.
Are you listening to
It's the stigma we're talking about. It's the stigma we're talking about, you know? Yeah. It's the stigma we're talking about. I mean, it's just like somebody has depression, you know, and you know, like mental health issues. People choose to live in denial instead of coming out openly. But if you mention something to somebody, that person could give you an idea. But for fear of gossip, you know, that people will not be, if you pass now, people will not be pointing at you, oh, this person has this person, you know, so a lot of people tend to go back to their shells and just close up and decide to keep it to themselves, and but it doesn't help. It doesn't help, you know. Yeah, go ahead.
You said that is common to both Nigeria, Congo, and India.
More common. And I said, it can affect any race. Yes. Any race. It's Oyibo's have it, blacks have it, everybody.
Italians have it.
Everybody has it. But you know, you see, probably because, as I said, the first diagnosis was made in 1910. So probably, you know, and in this part of in Chicago. So the Western world became aware of it earlier than we did. So this thing we are doing now back home, trying to prevent, you know, people marriage, you know, marriages to people that are ahead. They probably started it a long time ago. And if you start it early, chances are that you will get to a point where you will completely eliminate it. You understand? You know, so that's why we still have those issues, you know, more, just like every other health issue, it's not just this one.
So I think that's really very critical, because when you mentioned that it's part of the course is socio-economic. So when people come from one background, and like you mentioned, early marriage, they don't know what it is. Right?
They don't, exactly.
You see a lot of married together, but they don't know.
They don't know,
So it's a higher chance of producing more. That's why the numbers are, because of information. That's
just to add to what you just said, I think I know of a very enlightened family in Sudan. I know of this. Just Sobai.
Okay.
Sobai is from a very
very well-known family.
And also the grace of Bai was it's from the Mudus family. So they're very, very enlightened family. They got married. And they had no children. The kids were Sickle. I know about just about you come to our house, but then I know that most of the kids died. But they were Sickle.
Most of them died.
And they were very enlightened people. So it's not predominantly, it's not a factor.
I'm not saying that it's only socioeconomic, it's on somebody's socioeconomic status that matters. Some people can choose, even when they are aware that these are possibilities. Some people can choose to go into it. Some people tell you, oh, I believe God. I believe God that it will not, it's my enemy will have it. And that's the way people think. So the chances are that those are buying people. Chances are that they may not have known at that time. They may not, even though they are well educated and things like that, they may not, or and they may know and just choose to take their chance. Because as I said, the fact that somebody is there and somebody is there doesn't mean that they will have this thing in their family. Yeah, it doesn't mean that. It's not that the probability of having it is high. It's as high as 25% out of 100. Yeah.
The challenge I'm having here is that the so-called disease was regulated somewhere, and it seems to be regulated. Human beings, out of carelessness, from what you're talking about, ignorance, helped maybe to go further. The research that's going on, does the research go back to when it originated? Because that's where we should be talking about.
Nobody really knows where it originated from. No, but I said the first diagnosis was made in 1910. That doesn't mean that was when it started, or that it started in that community. Yeah, it's just that that's when somebody was able to do a test that gave him an idea that something was wrong, and be able to identify what was wrong with the patient he was seeing. Yeah, but how it started, nobody knows. Just like how life began, nobody knows how life began. So what determines what anybody's makeup is the person's gene. So this I don't know where. It depends on the story you want to believe in. The story of the creation and things like that. So so nobody knows where it started, and that's why you cannot. But the good thing is that science has been able to trace it to particular genes, in the human body. So that is giving rise to the treatment, the advances in treatment that have been made now. Yeah. Yeah, so, Oga.
Yeah, something about the socio-economic background of the people who have this done. Just a comment on that. It will affect the amount of money that society puts into research in the poorer people, whatever disease they have. Not what money is put. I mean, richer people. Which one's disease? Not more money is put. A question. It's about management and life expectancy. If there's a cure, there is managing people. I mean, there are all kinds of diseases where there's diabetes where it's managing.
Yeah, you just manage. Yeah.
Is the life expectancy getting better? Is there improvement? Is the management getting better?
There's no data really to say if the life expectancy is increasing right now. I don't know. I will have to check. That to see like the progression from 10 years ago to now. It will be something worth checking. I hope there are studies that one can lay hands on. To be able to determine that. Yeah, but chances are that the quality of life is improving. Yeah, that life expectancy will improve for sure. Yeah. So there's a chance that what the life expectancy was 20 years ago is not what it is now. There definitely should be improvements. Yeah.
Right now. It's not very common anymore. Because, like you said, if you're born here and they screen you at birth, then you start antibiotics and all that, and you followed up. So that, which is all about trying to avoid infection, which is the main thing, right? So I think life expectancy, especially at infancy, is
it has improved. And there's just to mention something. There's this thing that they do now. There's a test that they do for even babies in the womb now. Like they can go in there and they do what they call amniocentesis. Under ultrasound guidance, go into the womb and take the fluid that the baby swims in and test it and be able to determine if that person has that sickle cells or not. Yeah, it's done now. Just to prepare for life after birth.
So in order to answer this question, there was a seminar that was done in Chicago, 2008, in which some people went, sickle cell disease people, they went there, and they were just like a seminar. People used it on YouTube. Release was there. So the life expectancy of people with sickle cell disease before used to be around 26 years.
Yeah. Yeah.
26 and 3 years. Yeah. But now, according to your release, the seminar, it has reached 56 years.
Yeah. Yeah.
But even here now, I know people that have sickle cell disease who are at 76. So it depends upon management.
Yeah, it depends on management. Yeah.
Why people mostly, why the life expectancy is only here, but in Nigeria, because we don't have proper medical.
Yeah, don't have proper. Yeah.
Not care, nothing.
Don't even have the death.
So they leave them to die.
Yeah.
So that's why we don't know about the life expectancy.
Yeah.
But here, the life expectancy have also increased. Again, the best thing here we know now that is about this blood exchange.
Well, exchange will not really, it's not a cure. It's just
Now, what they do is, if you are lucky, they prescribe you that every 4 weeks or 6 weeks, you go to the what they call phlebotomy. Yeah, they take away some 2 or 3 parts of blood. And that will allow you to be healthy enough. The only thing which we're going to talk to you, another thing I'm going to do now about it is because the blood of white and our blood of blood of our the same thing. White blood, and according to the seminar work, they told us that the white people's blood is a lot of iron in their white people's blood.
Really?
Yes, they told us, yeah. And that's why when like my son goes there every year for blood test, they say that every year you go there for testing him for iron. That's why they encourage us to go to our communities and then the black people to donate it so that the problem of blood overdose won't be there. Even now, if you have their siblings or people who have the same blood, they can take blood from them and store it for you. For a couple of years, maybe 10 years. So every year, they will go every month, they will go just for you, take the 2 parts of blood and give it to you. In that case, then they can live as long as God permits.
Yeah, but the thing about the iron overload thing you're talking about is that people that receive regular transfusions are prone to that iron overload. I mean, it happens not just here. Also, any part of the world, once you receive, a lot of frequent blood transfusions, you stand the chance of having that iron overload. And then the role of Canada blood services is very, very important. They have a lot of campaigns, and sometimes you see them in malls, setting up shops, trying to entice people, encourage people to donate blood. Yeah, that is one of the benefits of having like an association like the Sickle Cell Association of Canada, which works in close partnership with Canada Blood Services, to advocate for people that have this issue, that need those services. But in Nigeria, who talks about that kind of thing? So somebody, okay, go ahead.
So from what you're talking about, I'm married. So now when you do the blood transfusion, does it suppress the generation of the?
No, it doesn't. It doesn't.
So what? Okay, so because so the blood that gets generated is what either you have the one that
normal one,
normal
and the
one,
sickle one,
and
yeah.
the so
Yeah.
if the person generates a lot of the sickle one, that's what the problem is.
Yes.
So what is the benefit of the
Blood transfusion. Yeah, the benefit of normal blood transfusion is that you get the good cells that are fresh, that will help your body function. Yeah, that's the benefit.
So that's not the benefit.
Yeah.
But from what you're telling me here is that when the sickle gets together, the major problem is that when they block the capillaries or whatever, because they don't. Yeah, so they block it. So how do you get rid of that when you infuse blood where those ones are getting blocked still?
Well,
what's the benefit?
It depends on the degree of blockade, okay? Depends on the degree of blockade. Yeah, by the time somebody starts having a crisis, having these symptoms, and goes to the hospital, and even ordinary infusion, drip, giving the person ordinary, when you are giving them drip, you don't want to overload them, so that their blood doesn't just become very watery. So you give it to them, and that helps to ease up that the flow in the blood vessel. You understand? So far the blood vessel is not blocked completely, like that to have led to somebody having a heart attack or somebody having a stroke. But people sicklers are also prone to having strokes. So if it hasn't gotten to that point of complete blockade of a blood vessel, then once you give the person blood that increases the volume, then the flow, the normal flow resumes and takes care of things. And then those cells that are come together will now be taken out of circulation in the spleen. You understand? And destroyed. And then between the spleen and the liver, processed, and you peel out the urine, the normal one.
The spleen and the liver sees it as abnormal.
Yeah, of course, the spleen sees it as abnormal. Yeah.
Okay.
The spleen sees it as abnormal and removes it from circulation. Yeah, that's why for most people, most sicklers have, most of them really, if you check their spleen is a lot of times enlarged. Yeah, because of a lot of those abnormal cells that the spleen takes out and processes. So it increases the workload on the spleen, which they try to cope with by getting bigger. The cells in the spleen getting bigger. Yeah. Yeah.
Okay. I know
sorry, madam, somebody raised their hand there.
No.
Okay.
Okay. We have we really have to just kind of move along because this space is timed and this is a wonderful presentation.